Thank you, Professor Marshine, for the introduction. Also, thanks to Professor I-ELCAP for the kind invitation. It's my pleasure to be here to share the review work about evolution of use of risk models in lung cancer. I will share this more in a technical point of view. So I have no potential conflict of interest. Lung cancer remains the leading cause of lung cancer-related mortality, and LDCT screening, such as NLST program, Nelson program, has shown the improved early detection and reduced mortality rate in the past 20 years, but although these advances has been achieved, there are still challenges remaining, including high false positive rates, overdiagnosis of indolent lesions, unnecessary follow-up imaging, and invasive procedures, and also difficulty in identifying individual who would truly benefit from screening. To address these limitations, many lung cancer risk prediction models have been developed to improve these screening efficiency and to identify these high-risk populations. So at the early stage, these lung cancer risk prediction models are mainly clinical factors based. So here are some representative models, including BAC and PLCO models. These models were aimed to predict 1 to 6 year lung cancer incidence probability, or the lung cancer death probability. And you can see the risk factors that incorporated in the model. At the early stage, they mainly consider the age or the smoking related variables. And later, like PLCO, this kind of model, they incorporated more clinical variables like education, BMI, COPD, or cancer histories. Some researchers have comprehensively compared these models on the NLST or the PLCO datasets. As you can see in this figure, the models of the discriminative performance for this model are better for the incidence death prediction than the incidence prediction. And among these models, PLCO and the BAC models perform the best with an AOC more than 0.68 on the NLST CD dataset. And similar trend can be observed in this figure. And still among these models, and PLCO and BAC model perform the best for the incidence risk prediction on these PLCO chest X-ray dataset. Also, researchers further analyze the sensitivity and specificity for these different models and NLST criteria. Still, BAC and PLCO model ranked in the top list, and they outperform the NLST criteria. So these models are mainly clinical factors based, and with the widespread adoption of CT screening, imaging become more important component for the lung cancer risk prediction. This has driven the transition from the clinical factor-based models to the imaging-based models. One well-known classic model is the Brock model, which not only consider the clinical factors, but also the nodule size, nodule type, nodule location, or the nodule numbers for the risk prediction. And later on, Longrat's refined the classification based on these features. In addition, Nelson plus protocol further incorporate this volume doubling time as a dynamic biomarker to predict the lung cancer risks. These features are mainly human defined, and the number of features is quite limited. So are there any features that human might not be observed, but the computational method can capture? So Readiness provides a new perspective for this solution. It extracts high-dimensional features, including first-order shape, or the texture, or the filtered features for the analysis. One study extract the Readiness features from the nodules on these 4 screening data sets, and they developed a risk prediction model, and their Readiness model has an AUC with 0.93, outperforming the PanCAN model, which are considered the patient characteristics and the nodule characteristics. More recently, deep learning models have been applied in this field as well. Traditional methods only focus on the features of nodules. They might overlook the features from the global lung, and this study assess the extra value for the global lung features for the lung cancer risk prediction, and they found out the integrated model with the global lung features outperform the nodule-based models. At the same time, molecular biomarkers with machine learning models also have been explored for the lung cancer risk prediction. Molecular biomarkers can be obtained from the blood, which might include ctDNA, cfDNA, microRNA, or protein-based features. They might reflect these potential biomarker changes associated with lung cancer development. And since they are minimally invasive, they can be complementary to the screening. However, these methods are still have been under investigation, and their role in the screening is being defined. So then the most recent models are the multimodal risk models. These models, for example, this one, they not only consider the clinical features, but also nodule features, and they incorporate the follow-up information like the temporal changes of the nodules for the lung cancer risk prediction. And their results show that using features in the multi-dimension, they can outperform these dual-dimensional or single-dimensional feature-based models. Similarly, these imaging and cfDNA-based integrated model also outperform the individual models. So there are a lot of promising results have been achieved. There are still some remaining challenges that we need to consider. First, it's about a model selection. It's still unclear which risk model perform the best and in which scenario each model should be applied. Second, we have seen the results from the Central or the Eastern European countries that lung cancer screening can be cost effective. And the molecular biomarkers can be a potential value to improve lung cancer risk prediction. But when we integrate this imaging screening and the molecular biomarkers together, can they still improve the cost effectiveness? And what's the role of the molecular biomarker, and should it be in front of the screening or behind the screening? Third, it's about the deep learning models. We have seen there are a lot of models can achieve an AOC more than 0.9, but do these models truly have this good performance? So is there any risks that they have this overfitting? I think it's really important to have this benchmark data set from multiple centers to validate current AI models and future AI models. As we can do with the Agile together. And finally, we probably need to further improve this model transparency. One possible direction can be that we can just connect these micro-level features like from the pathology or the genetics to the macro-level features such as imaging together to find out whether they have some connections. It help us to find some underlying biomedical mechanism for the models. So there are still a lot of steps that we need to do further for the lung cancer screening. And regarding to the question that are we ready for the integrated chest CT screening? At present, I think the answer is likely no. And although the integrated chest screening can help us to do this multi-disease assessment, but still we lack sufficient evidence for the cost effectiveness in these programs, and the need for validated clinically explainable models exists. So to summary, lung cancer risk models evolved from the clinical-based models to imaging-based models, more recently to biomarker-based models, and to the multimodal-based models. And imaging and molecular biomarkers can provide complementary information to might further support the accuracy for the lung cancer risk prediction. And in the future, multimodal models might enable more precise and personalized screening. Thank you for your attention.